Hi, everybody. My name is Abby Silfies, and I'm an executive director with the American Heart Association. I'm excited to bring to you the second episode of our Conversations from the Red Couch, a quarterly community conversation brought to you by the Lehigh Valley American Heart Association in partnership with the Lehigh Valley Heart Institute. It is my pleasure today to introduce you to our highlighted guest for this episode. On the couch with me this afternoon is Dr. Paul Corotto. Dr. Corotto practices at Lehigh Valley Hospital Cedar Crest in cardiology and has been one of the main cardiologists leading Lehigh Valley Health Network's efforts related to COVID. He has spoken about COVID and cardiology to his peers and Lehigh Valley Health Network's medical staff, and also has been heavily involved with the sports cardiology program. Thank you, Dr. Corotto, for joining me today, and welcome to our Red Couch.
Thank you so much for having me. I appreciate the opportunity.
So we're really excited today just to kind of hit you up and ask you some questions. Right now, COVID and heart health is something top of mind to our community. So if you don't mind, we're just going to get things started.
Absolutely.
Despite the devastating toll of COVID-19, heart disease still remains the #1 cause of death in the United States and worldwide. How do you recognize heart disease as a huge concern right here in the Lehigh Valley?
Well, I'm obviously biased based on what I do for a living, but I'd argue that it still remains mine, I think, as a health network, our top priority in many ways. I think, as you alluded to, despite current events, heart disease is still the #1 cause of mortality in this country. And for a lot of the patients that we see in the hospital or here in the clinic, it remains our #1 priority. So in the world of COVID, we have all been learning on our feet over the last 9, 10, 11 months and sort of adapting to that new reality. But I think in many ways, it's made us, I think, hopefully better physicians for our patients, specifically better cardiologists for our patients, but it's been a learning process. And so I think for patients and for physicians alike, it's important to we've been patient through that, but I think we're in a better place now than we were even a few months ago. So again, biased as a cardiologist based on who I see every single day, and related to COVID, some of the patients, and particularly the athletes that you alluded to earlier, I'm seeing more and more of these patients as the weeks progress, but I think it's important to keep in the back of our mind where our priorities lie. And I know for the AHA and similar for the Lehigh Valley Heart Institute, cardiovascular disease is our #1 priority, and we've been able to maintain that, I think, despite the challenges of the pandemic.
And thank goodness, right? The American Heart Association identifies that there are known effects COVID-19 will have on people with heart disease.
Yeah.
On the other hand, there are also documented cardiac side effects of COVID-19 on people who did not previously have cardiac history.
Yeah.
Can you elaborate on both of those for us?
So I'm glad that you separated it in that way, because I think it's an important distinction to make. And so early on in the pandemic, if you go back to sort of February into March and then March into April, the initial data that we had as it relates to heart disease and COVID initially came from China. And then we started to get data from Europe, mostly from Italy. And then as we got into the later part of March and into April, data started to coming out of New York City. And so in the beginning, the data sort of fit the trend that you might expect. And what I mean is that your older patients, your sicker patients, your patients with underlying cardiovascular disease. And for the most part, we break that up into coronary artery disease, so plaque or blockages in the heart arteries, and then also clinical heart failure, whether that's from weak heart muscle or from stiff heart muscle. But in the broad umbrella of heart disease, those patients who became infected with COVID tended to have worse outcomes. And so we knew that in the beginning, having underlying heart disease actually increased your risk of becoming infected in the first place, which can seem a little bit counterintuitive. But the take-home message there is that we know having cardiovascular disease also can be associated with having decreased immune response. So having an immune system that's not quite as good at fighting off infection when you are exposed to whether it's SARS-CoV-2, the virus which causes COVID-19, or just other respiratory viral illnesses. And so not surprisingly, we saw that amongst hospitalized patients, those with underlying cardiovascular disease were more likely to become sicker in the hospital. So more likely to require supplemental oxygen, more likely to require a ventilator, and unfortunately also more likely to die of their disease early on. And so I think it drives home even more importantly, this concept of making sure you're optimized from a heart standpoint, whether that's your coronary disease, your heart failure, your valvular disease, so that, God forbid, you become infected, that we can have you in the best possible state of health to fight that infection. But to the first part of your question, that is true, that those with underlying cardiovascular disease do tend to become sicker from their infection and do tend to have more complications, and unfortunately a higher rate of mortality than those that don't. It is separated though from this second concept that you alluded to, that there seems to be a certain percentage of the population who going into infection were unaware of any underlying heart disease or didn't have a diagnosis before. Thankfully, that is much more rare than that first group, but it ties into sort of the difference between the infectious disease aspect of COVID and the inflammatory response. And so for most people, when you're exposed to COVID, exposed to somebody who's shedding virus, it takes about 3 to 5 days to develop those infectious symptoms. The things we typically think of with other respiratory viral illnesses, congestion or runny nose, shortness of breath, cough, these sort of things. There's a certain percentage of the population, though, that develops the second stage, an inflammatory stage. And so oftentimes that inflammation affects the lungs. And so when you hear of people who need to be hospitalized due to COVID, it's often in the setting of needing supplemental oxygen due to some inflammation in the lung or a viral pneumonia that happens. There's a subsegment of that population where that inflammation also affects the heart muscle. And so there's this concept of myocarditis. And so I joke all the time with my patients that we are not creative as cardiologists. And so oftentimes things are exactly what they sound like. Myo is muscle, cards is heart, itis means inflammation. So quite literally inflammation of the heart muscle. In the early reports out of China and out of Europe, there was quite a few case reports of myocarditis. When I say quite a few, at least in the published literature. And so when we had our initial meetings as a cardiology group here at Lehigh Valley, that was our initial concern. You know, when we had our group meetings in March and April, the debate was how much of this will we be seeing? And thankfully, in retrospect, both here locally, nationally and internationally, those numbers have been less than you would anticipate. So while there are a segment of the population who don't have underlying cardiac disease, some do go on to develop inflammation of the heart muscle known as myocarditis, but those cases are relatively rare. And interestingly, they don't always correlate with disease severity, meaning having a worsening disease course from a respiratory standpoint does not automatically mean that you'll have a higher risk of having myocardial involvement of the heart muscle. And interestingly, also having involvement of the heart muscle doesn't necessarily mean that you'll have a worse prognosis moving forward as well. And so those things are a bit separate, but to the original question, there are definitely these two separate clinical entities. We know that people who have underlying cardiovascular disease are at a higher risk to develop infection, to develop complications, and unfortunately to pass from their disease, which makes it all the more important that we care for them ideally beforehand. Separately from that, there are certain patients who will have cardiac complications of COVID without having underlying disease, but those tend to be more rare.
Okay. Well, I appreciate that explanation because even as someone who reads about it every day, I wanted to take a few notes. So I appreciate that. So one of the things that we've been talking about are the last 10 and 11 months. And, you know, the favorite catchphrase of everyone is, how are you pivoting? How have you had to pivot? But I genuinely do want to know, how have you had to pivot the way that you care for your cardiac patients during this pandemic? And, you know, has it affected the way that people are receiving treatment?
It absolutely has. And so I think, you know, for us, at least here locally, and I think the trend would be similar nationally, there were sort of 3 stages. You know, there was the initial stage that, you know, late March through May, sort of the early stages of the pandemic. Here at our office at the Heart Institute, we were not seeing patients in person from late March through, I think, the second week of May. And so everything was telehealth and telecardiology, which I'll get into in a minute. There was that transition over the summer. We were playing catch up a bit for our elective procedures, at least in the state of Pennsylvania. The Department of Health had asked us to postpone any elective procedures. So as a cardiologist, that was a lot of elective heart caths. It was elective echocardiograms. It was elective electrophysiology procedures. And so there was that catch up phase, sort of late May through June and July, where we were getting back to those cases that had been deferred and also getting caught up to speed in clinic. I hate to ever use the word normal in reference to anything in 2020, but there was some sense of normal in the sort of midsummer months into the early fall, where we're back to seeing most of our patients in the office like we had before. Now, obviously with screening procedures in place that weren't there before. And then unfortunately, like many things over the last month to 2 months, as numbers have ramped up again, our approach has changed again. And so now we're sort of a hybrid approach where at least a few weeks prior to a patient's visit, we're tasked with going through our census for the day, the patients that are supposed to come into the office, and making a determination who are the patients that really need to come in to be seen physically. Heart failure patients might be an example, or those with more complex disease where you think that face-to-face interaction or a physical exam is really important, versus who are the other patients who maybe a conversation either via telephone or via video visit would be more appropriate. I think both keeping in mind to sort of protect the patients from us, to protect them from exposure that's unnecessary, and truthfully also to protect patients from each other to a degree, to allow that separation in the waiting room or as they're getting their vital signs taken and so on. And so I think the pivot at first was getting adept at telecardiology. And then the pivot since then was realizing how we can sort of make that a hybrid model that's best for the patients. And so there's no doubt that having a conversation via telephone or via video is different than having a conversation with your patient in the clinic. It changes the dynamic to a degree. I also think there's advantages to that. And so for me, what I like about video visits is often I can have family or caregivers on a video visit, which in the age of COVID, you're not really allowed in most scenarios to bring family members with you to a clinic visit. It makes reviewing medications a little bit easier. The patient has their medalist at home with them, or they have their pill bottles to go through one by one. And I think most importantly, it gives me an opportunity to review those basics that we alluded to before, making sure your blood pressure control, your cholesterol, your diet is where it needs to be to try to put you in the most optimum position possible from a cardiovascular health standpoint, so that should you be exposed or become infected, we have you in the best possible place. So we've absolutely pivoted. I hope that we're better now as we sit here in January than we were even a few months ago, but it's been a transition for everybody. And I think that transition is going to continue.
I mean, I think it will leave all of us, no matter what your professional background is, stronger after this year, because we have become such experts in adjustment, right?
Yeah.
And I think the healthcare field has just, they've been remarkable in the way that you guys have been able to pivot and keep people's safety top of mind.
Yeah.
Speaking of safety, the American Heart Association came out in July with a program called Don't Die of Doubt. It's a campaign encouraging people to seek medical care when emergencies strike, no matter what's going on in our community. Lehigh Valley Health Network had a similar public health messaging about not to be afraid to seek medical attention. What advice would you give people that may delay their care during a cardiac emergency?
It's a very real phenomenon. I think it's something that we saw locally first, meaning sitting in the hospital in April or May, there was less heart attacks coming in. There was less heart failure exacerbation coming in. There was less atrial fibrillation coming in. And it didn't make a lot of sense to us at the time. Where are the patients? There was a editorial that got a lot of press in the New York Times in May or so. And it was just titled, "Where Have All the Heart Attacks Gone?" And it was written by a cardiologist at Yale. And the point was exactly what you were alluding to, that we were seeing less of this. And we're always careful. We have that phrase that correlation is not causation, meaning just because two things seem to fit together, we're in the current pandemic, there's less MIs coming in, you have to be careful not to assume that they're directly related. In this case, I think that we have pretty strong evidence that they are, and that was a fear amongst patients, and a very real fear of wanting to avoid interaction with the medical system that may not be necessary. We absolutely saw more people coming in after 2 or 3 days of chest pain instead of 2 or 3 hours, or 2 or 3 days of shortness of breath instead of 2 or 3 hours. And so it's important to remember that we can still care for patients safely. We do it every single day. Just like I was alluding to before, we've adapted in the clinic, we've adapted in the hospital to keeping patients separate from those who are currently infected or those who are at risk. Here at Lehigh Valley, we have a huge Cedar Crest. We have a huge institution, 800 or 900 beds in total. There are COVID units, there are COVID rule-out units, and there are COVID-free units. And on the cardiology service, we do our best to separate as we can. Now, it's absolutely true that there is risk of exposure as you interact with the healthcare system, but from the level of paramedics to our emergency department to us here in the hospital, we do everything we can to minimize that risk as much as possible. What you don't want to have happen, the worst possible outcome in this, is to suffer a bad cardiovascular outcome. In the world of cardiovascular disease, that's usually heart attack, myocardial infarction, or stroke, by ignoring those symptoms that represent a true cardiac emergency and delaying your care. And so what we have seen is some negative outcomes of that. If you look nationally, out-of-hospital cardiac arrests are up. Mortality related to caring for heart attacks in the hospital is up. And again, you have to be careful to assume that those things correlate with the pandemic, but they sure seem like they do at this point. And I think a lot of that is that delay. So I think we as a community have to continue as best we can to comfort our patients, and that if you are worried, it is never wrong to pick up the phone and talk to us. If you're really worried about those emergencies, the right thing to do is come in, and that we can take care of you. Have confidence that we can take care of you in a safe way and get you the treatment that you need to avoid those adverse outcomes.
I think education is key, right? That is something that we have, as the Heart Association, been promoting, since the beginning of this pandemic, is to, not only to advocate for your own health, but to educate yourself about what is safe, and seeking that medical attention is so key. So let's pivot a little bit, and let's keep on COVID, but let's also talk about kind of the other pillar to your work. And one of the things that you mentioned earlier was working with athletes. COVID and its effect on athletes has been a national buzz topic. Yeah. People are interested to know. And so let's talk a little bit about what competitive athletes, as well as recreational athletes, need to know about COVID's potential effects on their cardiovascular health.
Yeah, so it ties back a little bit to one of the earlier questions regarding the risks of COVID for folks with known cardiovascular disease and those other people who are healthy and don't have known disease. Most of our competitive athletes fit in that category. So I said before that most of our early data came from that February, March, April time period. We then started to have some data into May and June that looked more into either your minimally symptomatic patients or your sometimes asymptomatic patients. And there was some at least preliminary data at that time that some of those people with more mild disease could potentially have cardiovascular complications, specifically the idea of myocarditis that we had alluded to earlier. When you have myocarditis as your, say, typical, mid-50s, I work out a couple days a week, or I play pickup basketball on the weekend, is a little bit different from a risk standpoint than a competitive athlete, meaning a competitive athlete is going to ask a bit more of their heart, whether it's in the training environment or in a competitive environment. And so the NCAA initially released a statement, I want to say late June into early July, suggesting that any competitive athlete, any collegiate athlete in that scenario who had tested positive for COVID should have cardiovascular screening. And then it was sort of left up to us as a community, what does that mean? They left it a bit vague. And so cardiovascular screening in the beginning, I think rightfully so, was fairly aggressive in terms of workup, meaning the last thing you want to do is miss something, so to speak. And so some of the local universities here in Lehigh Valley, first Lehigh University itself, and then expanding out probably to about 10 or 11 different institutions at this point in time, had reached out to our department and asked, could we establish a program to sort of streamline athletes so that they didn't get, so that we did, I think, appropriately treat them a little bit differently than the general population. And so for us, starting in August, we set up a separate, established a separate protocol here between myself, one of my partners, Dr. Dan Mikowski, here at Cedar Crest, and another partner, Dr. Ronak Patel at Muhlenberg, where we saw collegiate athletes separately. So they had separate clinic spots. In that scenario, in the beginning, everyone was getting cardiac imaging, echocardiogram. So we had separate echocardiogram spots. We would screen with EKGs, looking at the electrical pattern of the heart, and we would get lab testing for each patient, looking at something called a troponin level. Troponin is a part of the heart muscle itself that most commonly we look for when somebody's coming in with a heart attack to see if there's actual damage to the heart muscle. It's also very sensitive in looking for inflammation of the heart muscle, and so we would use it to screen in that same way too. And so in the beginning, that comprehensive screening was for every athlete who came in, whether that be asymptomatic, minimally symptomatic, or some more worrisome symptoms. As we got more data, so we saw just over 100 athletes even by the beginning of October or so, and as nationally we got more data, in a good way, we realized that myocarditis was less frequent than we thought it may be. And so we've adapted our approach a bit over recent months now, trying to separate things. And so what I counsel my athletes for now is to look for cardiac specific symptoms. So the simple way that I remember it is above the neck versus below the neck symptoms of COVID. So above the neck, to me, congestion, runny nose, cough, some of the typical symptoms you expect to have of the respiratory viral illness, fever counts in that category, loss of taste and loss of smell. Below the neck, we pay a little bit more attention to as a cardiologist. And so palpitations, a sensation that my heart is racing, my heart is skipping a beat, certainly chest pain, discomfort, pressure, anything atypical sensation in the chest. Shortness of breath, which can be difficult sometimes to differentiate shortness of breath due to COVID and something else, but feeling short of breath doing things that would not normally make you short of breath pre-COVID. And the last thing is passing out spells, feeling like I might pass out, and so on. That gets our attention a bit more, especially in the training population and the athlete population. And then duration of symptoms. If a patient even has infectious symptoms above the neck that I alluded to before, but they last longer than 10 days, we tend to screen more aggressively in that category. And so whether you're a competitive athlete or someone who just trains and works out regularly, I think remembering that above the neck, below the neck sort of differentiation in symptoms is helpful. It's also never wrong to pick up the phone and just talk to us. And so whether you go through your PCP first or request an appointment here with the Heart Institute, we are happy to walk through those initial symptoms. I joke with my athletes all the time, the worst thing I'm going to do is have another conversation with you. And then sometimes that means adding some additional testing, but we would rather know than not know. And whenever there's doubt, we want to be able to reassure our patients that it's safe to train again, it's safe to work out again, but we want to have confidence in that statement. So I said earlier, myocarditis is rare. It's thankfully we're learning that it's even a bit more rare than we thought early on, but it's still important. I often say to the athletes that a low risk is not a zero risk. And if you see enough athletes, eventually you will have someone that comes back with something more significant. And so I think that part's important to keep in mind. But more than anything else, we want to be able to reassure the patients so that post-COVID, they can get back to whatever semblance of normalcy they had before. And from a cardiovascular health standpoint, I want my patients to train and to work out like they want to. So it's important to get back to that as safely as possible.
I love the safety and confidence. And I think those are two things that we're all going to need to focus on moving forward.
Yeah.
So Dr. Corotto, I think the last big question I want to ask you today is one that will give you an opportunity kind of just to show your points of pride over the last year and the trial and error of COVID-19. The American Heart Association has had an impressive response to COVID-19. We established a significant rapid research fund and surplus of $2.5 million. And that is kind of a point of pride that I'm able to share with people of the body of work that we've been able to accomplish in the last 10 months. Has there been any research on COVID-19 or on the vaccine that is happening at Lehigh Valley Health Network or through the Heart Institute that you would like to highlight for us? What is a point of pride for you?
So we were part of the initial Pfizer trial for their vaccine, which I think for all of us in the summer, looking for that ray of hope, looking for something at the end of all this to look forward to. The vaccine was sort of this thing on the horizon that we all hoped was coming at some point. We didn't know when. So I think when we first, at least for our group, realized and were informed that we'd be a part of the initial Pfizer trial, was quite exciting to through the grapevine know some colleagues or some it was whether physicians or just other people who work within the network who were able to enroll through the summer and into the fall in that trial was something really exciting for us. And so to be able to be a part of that initial data, I think all gave us pride, and I think rightfully so. And I'm really proud of the way that we have established our own vaccination program once it did receive emergency use authorization. And so for us, I believe it was just before the Christmas holiday, so maybe around the 20th or so, we started vaccinating. First here, and I think this makes sense, our institution chose those most at risk from a work standpoint. So for us, it was our infectious disease doctors who have been on the front line since the beginning of this, our intensivists who are in the intensive care units caring for COVID patients, our hospitalists who are mostly internal medicine doctors who will work day and night for many of them in the hospital. And then from there expanded out to other members of the network. And so we've been going now, today's the fourth week, I think, of vaccination, or even the fifth week. And so I've been proud of that rollout, sitting in the chair and having that experience myself. So for me, it was just before the holidays was emotional in a lot of ways. It's been a long ride for many of us. And to look around that room and to see colleagues who you've been working with the last 9 or 10 months, experiencing what you've experienced. And then I think on top of that, knowing that now we've rolled it out to our patients. The first day, I think it was about 2 weeks ago, where our patients over 75 years old were able to enroll in our vaccination program. To see them in that line, and it was a long line, makes you happy. There was relief is the wrong maybe emotion to feel, but some at least sense that we're really getting somewhere now. And so that the pride for me is being a part of the initial data gathering collection process as a part of the trial, and then seeing the effective rollout since we've gotten the vaccination program going.
I love that. I love it so much because it is a summary of exactly where we hope everyone can get to a point of feeling a little more secure, a little safer, a little more confident, and hopefully a little more healthy. So I just want to thank you so much for being with us today. If you had to leave us with one thought, and yes, I'm putting you on the hot seat because this is not in your notes, anything you want to leave us with today?
I think what I alluded to before with the athletes, never be hesitant to pick up the phone and ask. And whether that's your PCP or whether that's asking the PCP to contact whether our office or any cardiologist office that you're familiar with, or our office directly, that, you know, we are here to answer those questions. There is no silly question as it just relates to heart disease and COVID. Again, the worst thing that I'm going to do to you is ask you to come in to have another conversation, or after that conversation, some initial testing. But you would, in all of this, you would rather know than not know. You know, that sometimes there's that fear of the unknown. You don't want to ask the question because you can be afraid of the answer, but you'd rather know that answer in something like this so that we can keep you as safe as possible. And so that, I think my message to the patients or to anybody listening would be to try to eliminate that sense of hesitation or that worry that you're going to ask a silly question or bother us at a time that we're all quite busy. That's true. And we're going to be busy whether you pick up the phone and call or not. So we want you to pick up the phone and call. And I think that we can help patients along the way. The education component that you alluded to earlier, I think we have to continue to strive to give the patients the information that they need to keep themselves safe, their family safe, and so on. I think we can continue to do that.
I so appreciate that. And, you know, the timing couldn't be better. We are a week away from National Heart Month, and between our organization and yours, and together collectively, we will be sharing out so many educational resources throughout the month of February. So we really ask people to please check heart.org, to check our Facebook pages, to follow both the Lehigh Valley Heart Institute and the Lehigh Valley American Heart Association, as we promise to continue our education and awareness activities together. So thank you, Dr. Corotto, so much for joining me on the red couch. Maybe someday we will actually be able to sit on a couch and talk, but for today, this was wonderful, and thank you very much.
Thank you so much for having me. I appreciate the opportunity.